Hello and welcome. Let me begin with some shocking statistics first to lay down the context for today's conversation. But if we look at the trends, adult obesity has more than doubled since 1990, and adolescent obesity has quadrupled in the same time frame. More than 90% of the diabetics live with either being overweight or with obesity. And that is a shocking statistic. And not just a shocking statistic, it's a wake-up call. As a clinician myself and as a healthcare industry leader, I have seen obesity driving up and causing worsening of diabetes, cardiovascular diseases, and in some people posing serious mental health challenges. Today, we'll see and explore what this means globally for India and for how patient-centric solutions can drive a positive impact. Welcome to a conversation, an exclusive conversation on obesity, from global crisis to patient-centric care. Joining me in the conversation, to my right, Dr. Marc Andre Cornier. Thank you so much, Dr. Cornier, for joining us. He's the immediate past president of the Obesity Society, and he's also the professor of medicine and director of endocrinology, metabolics, and diabetes at the Medical University of South Carolina. Also joining me at the far end is Mr. M.V. Ramana. He's the CEO of Emerging Markets, Branded Markets, and India at Dr.Reddys Labs. So my first question addressed to you, Dr. Cornier. Let's start with the bigger picture here, right? How do you see the global burden of diabetes and obesity coupled together? And why is it important in this to frame obesity as a disease rather than just as a lifestyle issue?
Yeah, these are great questions. And first, thank you for having me today to join you in this discussion. It's a pandemic. Obesity is a pandemic, and more than 40% of our adults on this planet have obesity or overweight, and those numbers are just continuing to go up. And so it's staggering. And what's changed is this used to be a disease that we only saw in higher income countries, but now this is becoming a major problem in our lower and middle income countries, where access to healthcare is even harder and more difficult for our patients. So this is a major concern. And we really are changing kind of the narrative that obesity really is at the core and causes all these other complications, that it's not merely just a risk factor or a comorbidity. It's actually the cause of diabetes, sleep apnea, cardiovascular disease. And if we could treat obesity first, earlier, we would make a much bigger impact at slowing this pandemic and turning it around.
Wonderful. I see that you're stressing on the fact that obesity is a cause. And as I said, it drives and worsens these diseases. I've also heard you and other experts opine on the brain and also on the behavioral aspects of managing obesity. Can you expand on how behavioral and psychological interventions and sort of support offered to patients would go a long way in helping sustainable weight loss?
Yes, that's an excellent question. Obesity is a very complex disease. It's a heterogeneous disease. It's not all the same. But clearly there's a neurologic component to it and a metabolic component to it. But there's also a psychological component. It's not dissimilar to most of our chronic diseases where there is always a behavioral component to it. I think, but unfortunately, obesity has really been said, this is a willpower problem. This is a behavior issue. But underlying all this is a genetic predisposition to excess adiposity in the right environment. And what we've seen is that our environment has changed over these many decades, which is also probably why our lower middle income countries are suffering now, because there's been an industrialization, a change in the workforce, and more food availability. And so the brain is not wired to be able to handle these changes in our environment. And so you take a genetically predisposed individual, which is most of us, put them in the right environment, and they develop overweight, and that leads to obesity and then the complications. Lifestyle is at the core of treatment. And I see it even mostly at preventing obesity, if we could change our lifestyles. But it's very difficult. Taking an individual and sits all day at a desk job and convincing them that they need to be more active. Well, where in their day are they going to be more active? How are we going to change the food environment? These are very hard things to do, but critical. And we must start there. But I think because weight management is so difficult and because weight loss triggers a whole set of compensatory mechanisms, peripheral hormones, neurologic changes that enhance food intake, people regain weight. And that's where medical therapy or surgical therapies can really be important in our management.
Yeah, and this resonates with what we see in clinics. I mean, many patients and people with weight issues do turn up and they may know what to do. But there are factors that affect them in daily life. There's stresses. There's the environmental milieu in which we exist and the societal pressures. Now, from a clinician standpoint, structured programs, counseling, the support that you spoke about, lifestyle modifications, all go a long way beyond the prescription itself. In India, this is even more important. You just mentioned about what happens when you're in a certain environment. And I've coming straight back from a festival which we all celebrated, and we've seen how food is very central to this social occasion, to the festivals, and what happens when we just give in. And it's very easy to give in and very difficult to resist. So moving on, since we're talking about India, let's bring this conversation closer to India. India is witnessing a very, very rapid rise in obesity and diabetes. And sometimes, and as you referred to as pandemic, we've been calling it the twin epidemic. Now, when you look at countries like India or India itself, what stands out for you, sort of particularly?
Well, I think the first thing is the reality is that while the rates of obesity, as we define it, are not necessarily high in India, the total number of patients or people living with obesity is number 2 in the world, right? With China being number 1, right? And that's sobering statistic, right? And so it's a different obesity that we see here in India than we see maybe in Europe or United States, in that it's mostly abdominal, visceral adiposity. And the difference is that at a lower BMI, you have more complications. And so genetically, individuals from South Asia and India are at greater risk for developing this central adiposity, which then leads to diabetes, dyslipidemia, fatty liver disease, et cetera, et cetera. So that's the concern, is that many people are being underdiagnosed. If we only use a BMI as a way to assess obesity, I think we're missing a lot of people who need or could deserve treatment at an earlier phase.
So that's a good one that you brought up, the good point that you brought up on the phenotype that we have in India, especially in China and India. The thin fat phenotype with central obesity, the visceral adiposity that you talk about. BMI, there are multiple measures, the waist to hip ratio, the waist circumference, the waist to height ratio. Now, what would be an ideal measurement to know that the person has adiposity or obesity?
I mean, I think many of our newer guidelines have really been pushing beyond BMI as a way to diagnose obesity. And, we've been talking about waist circumference as a good measure, an easy measure. It's cheap, it's free, right? To assess someone for central obesity. We've been doing this for decades, but nobody does it. So how can we reframe so that we can get people to actually do a waist circumference? So I think a waist circumference by itself is good. Our colleagues in Europe really are pushing for a waist to height ratio, which I think makes a lot of sense. And it's an easy one. If it's more than half, then you're in trouble, right? So it's a fairly easy number to say. But I think that's a strategy. But I think the reality is we need more research here. We need better ways to assess for adiposity, whether it's central or general, whether it's using technologies like BIA or other technologies, or can we develop a biomarker, a blood test that helps, adiponectin to leptin ratio, things like that have been looked at. I think we need more research, but until we have that, I think using waist circumference and potentially the ratio to height as being the easiest, because if you do waist to hip, then you have to do 2 measurements. That more error, more problems with that. So I think we need to educate our clinicians, because it's an easy thing to do.
Right. So what is coming out more as I hear you speak is that we need to use the simple measures that are already available, educate our physicians while we wait for important biomarkers and important research to throw up more biomarkers for central adiposity. Good one. Ramana, let me move to you. What are some of the India-specific challenges that you see, especially with access to effective care and effective obesity management?
Access is a major issue in India. Historically, advanced anti-obesity medicines, particularly the GLP-1 based therapies, have been very expensive and limited only to a small segment of patients. In addition, obesity is still underdiagnosed and often not treated as a primary condition. So, people reach clinics with complications.
So as a follow-up to that, Ramana, where do you see the patient falling through cracks? For example, there could be, one of the things is awareness, the other thing is stigma that you spoke about, the affordability, or even continuity of care, and that happens in all chronic diseases. So what are the gaps, and what role can the industry play and pharmaceutical companies like Dr.Reddys play in helping patients bridge those gaps?
Most drop-offs happen at 2 critical points: early recognition and long-term sustainability. Many patients don't identify obesity as a medical condition, and even when they start treatment, sustaining the program is hard. That's why we as an industry need to go beyond medicines, developing dedicated centers of excellence for obesity care by providing adequate infrastructure, empowering the healthcare providers for orchestrating patient-centric conversations, nutrition solutions tailored for Indian needs, and introducing a patient support program for behavior change, treatment continuity, reducing the stigma, improving the adherence. And of course, this should deliver better outcomes.
Thank you. Thank you for that, Ramana. So now, Dr. Cornier, as a clinician, what is your perspective? How can we bridge these gaps that we just mentioned? The awareness, the stigma, the inability to turn up for treatment.
There's many things are required, right? We need to, one, work at the public health level to convince the population that obesity is a disease. It's not a cosmetic concern. It's not just a weakness, a willpower issue, that it is a true disease that needs to be treated, and it's serious, that relates to complications. We need to also work at the healthcare professional level, because we have many healthcare professionals who also don't accept that obesity is a disease and still think that it's a weakness. And I always like to say, no one chooses to have obesity, right? So work needs to go at continuing education for our healthcare providers, whether they're specialists, but really at the primary care level, because where so many people are being cared for. But it needs to happen also at the medical system payer level and at the government and policy level. So we need to have an attack at all of these. And, in the U.S., we've been working on this, significantly in different ways, but raising awareness, I think, is a critical. Education. We need proper guidelines. That we have too many guidelines that have different recommendations. So we need to have a more unified. I was part of a global task force for obesity, so we hope to have that published here in the near future, which will help many countries who don't have their own guidelines. So these all are important to help our providers, but also the policymakers.
So could you, Dr. Cornier, walk us through the obesity treatment and how it has evolved very briefly from the lifestyle modification to the novel pharmacological options and, excuse the pun, but cutting edge surgical options which are available now for patients?
I mean, it starts with the basics, which is lifestyle, and that's what we had initially. And it works. People can lose weight in the short term. The problem is people can't adhere to these lifestyle changes long term, partially because the body compensates and turns up the systems that tell you to eat more. And so people typically will regain the weight after 6 to 12 months. But that doesn't mean it's not important to continue. Medical therapy has been around for a long time, and we have many different medical options. And these help work at the at the cause of obesity, centrally especially. Most of these drugs work either through appetite suppression or satiety inducing, whether it's phentermine, topiramate, any new bupropion, and now with the GLP-1 related and based therapies, which are very powerful. These medications work on the physiology or the pathophysiology per se, and help people not think about food as much, not be as hungry, be more full. That allows them to follow hopefully a healthier diet without having to count calories, and leads to sustained weight loss. I think the shift has to be, though, that we have to treat this as a long-term treatment, and how do we do that? How do we afford to do that? Do we have treatments for weight loss and a different treatment for weight loss maintenance? So there's many things that are evolving. And then there's surgery and endoscopic procedures, which have their place. Some people are worried that, with these medicines that are so powerful, we don't need surgery anymore. That's not true. Surgery is still an important treatment option for many of our patients, especially those who already have severe obesity with severe complications. Surgery can be life-saving for many of those patients.
Great, wonderful. You mentioned the newer therapies, the GLP-1 based like semaglutide. There's been a lot of excitement and interest around these, not just from the healthcare providers, but also from the patients alike. So what makes them different from the older therapies that were available?
I think what's different is the older therapies weren't necessarily targeting specific neurotransmitters or brain regions that only focus on appetite. So then they had issues with side effects, this and that. Where the GLP-1s really trigger the GLP-1 receptor, which has more specific control of appetite regulation, whether it's at the hypothalamus and reward centers or even higher brain centers. So it really gets more at the pathophysiology of obesity than some of the older agents, which were more of a general effect on appetite. And what we've seen is with these treatments, we get significantly more weight loss because of that. And I think that's the dramatic difference. Plus, we have added bonus. We never saw, other obesity medications lead to cardiovascular benefit or other healthcare benefits. Where now we're seeing that, with semaglutide, tirzepatide, where we're seeing, reductions in cardiovascular disease, reductions in heart failure, new diabetes, improvements in liver fibrosis. So it's pretty dramatic to see these effects.
Yeah, it's surprising that it's probably one of the wonder medications that's come in the recent past. It tends to affect many organ systems and lead to better outcomes. And hopefully the weight loss maintenance, as you said, is something in our hands already. So Ramana, moving on to you. Over the years, Dr.Reddys has been working in bringing innovative medicines and helping patients access this across the globe, not just in India, but across the globe. Could you please throw some light on how Dr.Reddys, we at Dr.Reddys, are approaching innovation, especially with a focus on managing obesity in the longer term?
Our focus has always been on advancing innovation while ensuring accessibility and affordability, so that patients globally can benefit from novel therapies that improve the standard of care. Diabetes and obesity are among the fastest growing health challenges globally, with India being one of the most affected countries. To address this, we have expanded our nutrition business to provide personalized care that support patients in managing diabetes more effectively. In parallel, we have built deep expertise in peptide research over the years, enabling us to develop the next generation therapies such as the GLP-1 like semaglutide. These efforts reflect our commitment to delivering holistic care and improved outcome for patients not only in India but outside of India as well.
So Ramana, that's very heartwarming to hear, and that's true patient centricity. It's about making care accessible and practical for patients in their daily lives. What other initiatives are we driving at Dr.Reddys to achieve longer-term obesity management?
We operationalize patient centricity through many layers: early risk identification, culturally appropriate nutrition and counseling, digital engagement for adherence, equitable access via pricing support, and outcome tracking. This basically flows from our mission of good health can't wait. The goal is a long-term partnership with patients and clinicians rather than a quick approach.
Thank you. How, Dr. Cornier, do you sort of structure a conversation and a treatment plan for a patient with obesity who is seeking treatment for the first time and is seeing you for the first time?
Right. I mean, it's so important that the patient is at the center of all this. For many of our patients, they aren't seeking help for obesity. And so there, the challenge is, how do you address it? And we recommend you ask for permission. You see it as a problem. Is it okay if we discuss this? I think that goes a long way. For the patient who actually is there because of their obesity and they want help, I think that's a step already in the right direction. You have them there, so let's take advantage of the situation. I think it's very important to talk about obesity as a medical disease, not as a cosmetic issue, not as just a behavioral issue, and really medicalize it in a way. And talking about this is a chronic disease. We're not talking about a short-term fix. We're not going on a diet to lose 30 pounds and then we're done, right? We're not going to start a medicine for 3 months and finish, because the obesity might improve, but then if you stop the treatment, it just comes right back. So we have to have an upfront discussion about the goals. And part of the goals are an amount of weight loss for patients because they want that number. But again, emphasizing that we're not treating a weight per se. We're treating a disease, obesity. We're concerned about the overall health and the benefits that they will receive. And to get that, you need long-term treatment. So right off the beginning, that's what I have a conversation about, is that this is a disease that needs long-term treatment. It's a long-term relationship with the provider and the patient. And we discuss the benefits and the risks of different treatments and look at all the options. It's not just, I'm going to write a prescription here, go take your semaglutide and see me in 6 months. That doesn't work, right? We need to be holistic and comprehensive about this.
Thank you for that and for guiding us how we can structure the conversations and how the healthcare providers can look at this. So before we close, can you give your one message, which would be a key takeaway for the people who are watching this show?
Well, I think for me, the key message is that obesity is a complex, heterogeneous, chronic neurometabolic disease, and that's how we have to look at it. And that we need to treat it earlier. Kind of the saying that we've been sharing is treat obesity first. Treat it before we get to the complications. But treat all patients in a holistic way, comprehensively, and but that we have to work closely not only with our patients, but with our other healthcare partners and our policymakers to be able to give access to our patients.
Nice one. Ramana, message from you, please.
For me, access to effective treatments is improving, but these therapies must be used responsibly and equitably so that more people, not just a privileged few, benefit from these scientific advancements.
Thank you for that, Ramana, and thank you very much both. So I would like to close this by saying obesity is not a personal failure. It's not a stigma. Right? It's a complex interaction of biology, of genetics, as Dr. Marc told us, of the environment and the society that we live in. It deserves the same respect and the same seriousness that we accord to other chronic diseases. And it's not something that deserves a quick fix, but it requires compassionate care, long-term care, and broader access to effective medications. Thank you both for helping us address these issues, or at least begin addressing these issues. And I hope we can provide our patients with better care for the coming years. Thank you.